they are ready. Okay, so welcome everyone to this Dine and Learn session, coming to you remotely. Dean and I are both in the Dine and Learn working group as well as the ADHD, so we'll be both hosting and presenting for today. The topic, as you know, is adult ADHD and primary care, diagnosis and treatment. In particular, we're going to be presenting a pathway that the ADHD committee worked on that you can access on the Provincial Pathways website. And that will guide you through how to diagnose and treat adult ADHD. Okay, so as per the usual Dine and Learn format, there's going to be a presentation for about an hour, and then we'll have about a 30-minute Q&A afterwards. If you have questions as the session goes, please put them into the Q&A bubble at the bottom of your screen. So not the chat, but to the left of that, there should be a Q&A. If you don't see the Q&A, you should have at some point there 3 little dots for more options. And if you click on that, you should see a Q&A option. Okay, slide. So I'll start by acknowledging that we're very grateful to be able to work, play, and live on the traditional unceded territory of the Coast Salish Nation, including the Squamish, the Tsleil-Waututh, and the Musqueam Nations. Slide. So as I said, Dean and I are presenting. Neither one of us has anything to disclose. For those of you who don't know me, I'm Geneviève Lauzon. I'm a GP on the North Shore for many, many years, currently working in a group practice in West Vancouver. And Dean and I were both in the division from the outset and working in a lot of other mental health initiatives. Okay, slide please. So this particular pathway was created by this division group, and it was funded through a shared care committee because we have psychiatry colleagues that were involved in the project as well. Slide. So to start, we just have a few very, very brief questions. So if you can join the slido.com by clicking on the QR code that you see here. So we'll give you a little bit of time to do that. That's helpful for us from an evaluation point of view to see what the attendees, where you're at before the session. I'm going to try to find the balance between giving enough people a chance to answer, but not spending too much time on this. Maybe we'll go off to the next question, Alex. Next slide. So this is the second question, asking about your comfort level in starting and managing the meds. Maybe a little bit less comfort with meds than diagnosis. Okay, next slide. The next one is, how comfortable are you with doing the longitudinal maintenance? And this is the last one. Okay, that's good. Next slide. So this is the objectives for the session today. We want to discuss the benefit of leveraging primary care relationship to identify and diagnose, and then we'll walk you through the pathway and go over some resources and clinical tools. Next slide. So the problem when this first started about 4 years ago for us, we know that we had the ADHD clinic, the regional BCH clinic was located in the Hope Center at that time. And in 2021, they had to actually stop taking referrals because the wait time was way too long. And part of that is because of how common ADHD is. So it affects about 5% of adults, but is significantly underdiagnosed and undertreated. So even people who have a diagnosis, maybe at best a quarter of them are receiving treatment. And so we know that long waits to access care leads to problems for patients. There's a big cost to patients as well as society with increased risk of accidents, motor vehicle accidents, premature death, STIs, and patients often then end up turning to private or online providers for quicker diagnoses. Next slide. So why primary care? And so the primary care physician is well positioned to do this. We already manage a host of chronic conditions. We have a good relationship with our patients. We know them well. So it's ideal for diagnosis. And as of 2023, in a study by Dr. Berghall, the primary care practitioners actually diagnose more ADHD than specialists do. Next slide. So this is our favorite slide. This is our little roadmap to success. So it started with a pilot project on the North Shore. We had a small group, 8 primary care practitioners. The idea was to try to divert patients from the ADHD clinic. So amongst the groups, 63 patients were managed. 37 patients were able to be diverted from the clinic. This was over a 6-month period. So it showed us that primary care practitioners can manage uncomplicated ADHD with the proper supports. And this leads hopefully to a decreased psychiatry burden and then can improve access to more complex patients to psychiatry. So then there was still the issue of how to reach a larger number of primary care practitioners. And that's when we came up with the idea of the pathways development. So this is sort of an at the elbow information for primary care practitioners. So we worked on that locally and then with an advisory group that included doctors from a number of health authorities. And then we launched the pathway officially this past February. We were lucky in that UBC decided to do a half-day teaching on ADHD and invited us to join and kind of followed the pathway as a map to their day. So that happened in March. And then going forward, we're hoping to continue to embed ADHD training and education into primary care with events like today and word of mouth and just colleagues helping colleagues. Next slide, please. So the pathway for us here is for uncomplicated adult ADHD. So what does that mean? So this could be people who were diagnosed in childhood and now they present as adults because a lot of people who have a diagnosis as children don't necessarily continue to fit the criteria as adults. It's still a good idea to review how they are and see if they still qualify, if they still fit the criteria for ADHD. Could be somebody with no significant history, but is questioning whether they have ADHD. I'm sure you have a lot of those patients. It could be someone with ADHD with mild or moderate, either anxiety, depression, or substance use. We still consider those uncomplicated. And it could also be ADHD that was not previously considered. So now I'll pass it over to Dean, who will introduce you to the pathway and guide us through the diagnosis section.
Yeah, thanks, Genevieve. Hi, everyone. Good to see you. I'm Dean Brown, GP on the North Shore, involved with mental health, among other things. And it's been a ton of fun, actually, to be involved with this project, as Genevieve has said, going back several years, and to see that there's been uh, good interest on the North Shore with this, first of all. But one of our tasks, as Genevieve was saying, was to look at can we create a button? That was what we were really after, was a button on pathways. So it took a lot of work, but we finally got the button. So if you want to see the button, you go to pathwaysbc.ca, which we all know how to do, and in the search box you put ADHD adult or ADHD adult care or some such thing. And the top item that will come up is the pathway. And just to say the pathway, and you're seeing the front page of it here. And if you click on any of those boxes, it'll take you to a specific place. But the way we've got this thing structured that we hope and we think works with primary care providers is a series of small visits. So we don't forecast that you'll be sitting down talking for 40 minutes with someone because you do counseling or whatever. We're trying to stay within the confines of what a primary care provider can do. And frankly, what a patient with ADHD might favor is maybe short, more frequent visits where just a modest amount of territory gets covered every time. So that's really what this is all about. And we've tried to create it so that at each visit, you have the tools in your hands to do whatever it is you need to do with the patient that day. So one of the things that we really want to start with is pointing out that ADHD diagnosis is not a one-stop shop. It's not one thing where you fill out a survey or ask a couple of questions and you're there. We consider it to be like any other form of primary care where you reach a diagnosis after assessing a lot of things, the history, the physical, previous history, what else do we know about all of this with the person? Um, and come to a considered judgment about what do we think is going on. So that's how we see ADHD. So we're really trying to normalize it into the kind of usual stuff that we do. Um, so just looking at the very first big box there, the pre-visit, consider ADHD if, and I call that visit zero. Because that's where the patient might say, I wonder if I've got ADHD, or you, the doc, might say, I wonder if maybe some of these things we're talking about what might be ADHD. And then you can say to the patient, uh, we have I have something in mind. We can deal with this. It's going to take a series of visits. We'll need to meet maybe every 2 weeks, something like that, and a good few times to figure out whether this is ADHD. It's not something we can do in one quick sit down. And same thing if we arrive at that, then we'll come up with some treatment, but it'll be the same thing. It'll be a series of steps and we'll reach the destination in a good way. So that's what our pathway is intended to do, to support you in that path. Next slide. So this is kind of the visit zero moment where you might say, well, what about ADHD? And there are all kinds of things you might look at, and I won't go into detail here because there's a lot of information on each of the slides we're going to see. But some things like substance use, impulsivity, and all of that. What about psychosocial adversity and relationships? Or maybe just cumulative exposure to adversity at an early age has been shown to create to indicate that ADHD might be there. Head injuries can cause or result in ADHD, or it can be from ADHD. ADHD can lead you to do more impulsive things and get head injuries. So, are any of those little flags that you might be aware of? And again, other correlations, school, learning, chronic interpersonal difficulties, relationships never quite working, having to move on, impulsivity, executive dysfunction, and so on. So those are just some of the scenarios. And then if you think any of that's there, then you start going into the visits. Next slide. So these are the kinds of things we look at. Visit one and two might be developmental history. So we see ADHD, thinking of it in the right way, as a neurodevelopmental abnormality. It's a neurological condition that really arises and becomes apparent in childhood. It's hard to diagnose it then because childhood is childhood. But if there is a pattern that goes back all those years, then that the person might say, I did have a difference in learning. They said this guy's unmotivated. He seems to be bright enough, but doesn't seem to want to work or pay attention in school. And some of these other things. Did you walk, talk, or play similarly, or were you different from other kids in certain ways? Did your mom smoke? Were you exposed to a lot of that? Complications at birth? Were you premature? Just some of those things. You might at that point start giving them surveys to look at some of the childhood incidents of things, something like the WURS or the SNAP 4. Um, Either of those tools could be handy to give the person at this point. And as you know, just a quick reminder, Pathways lets you provide those tools quickly, and you'll see the little envelope on the slide there that says if you click that envelope, then that will let you circulate that thing by email to that person very quickly and easily so they can complete it by the time you have the next visit. So then you explore that developmental history and have a look at it. Next slide. And then you have a look at the adult history. And again, looking at some of those same things that we've talked about and correlations that we mentioned. So this is really just repeating that same slide that we saw a moment ago, but looking at what are some of the things in adult history that might make you think along those lines. And again, you might want to give them the ASRS, adult rating scale, or the Whiffers scale. And again, you can email those things to the patient right away in the moment if you decide that's the right thing to do. Um, and next slide. And then we want to walk through medical comorbidities to say what are these things out there that might have a bearing on this. Family history. Is there a family history of ADHD, for one thing, because we think it's strongly genetic? Another thing might be family history of substance use or mental health challenges along the way. Those things might have you thinking a little differently about this. Dementia, you could consider that undiagnosed ADHD in an adult might be mistaken for early dementia, and sometimes by addressing that, thinking about it, you may change the trajectory of what this person's care looks like in those later years. Hormonal considerations, we know there's more and more focus on what about hormonal change in life, especially for women. What are the impacts of those? That again, the hormonal changes may become more uh, compelling somehow, and you think, yes, I guess menopause is a big deal here for this person. Turns out it's actually ADHD influencing the menopause, and it just becomes more apparent at that time. Or conversely, the hormonal changes might unmask ADHD to look at it another way. Sleep apnea could be in the conversation as well. That might contribute to ADHD symptoms. Head injuries, again, can cause ADHD or result from ADHD. Is that in here somewhere? And again, environmental factors, some of the things that you can think of that might have a bearing on this. History of seizures, environmental exposures, and certain types of seizures may look like seizures, but they might be ADHD mimicking as petit mal or something like that. Next slide. And then substance use. Again, we've touched on the fact that uncomplicated ADHD, which we're talking about, would be, for the most part, not addressing a deep-seated substance use issue. But we're aware that modest substance use happens not uncommonly, obviously, in our primary care patients. So we feel that if there's alcohol or cannabis use that we consider mild to moderate, that might still be in our path for continuing on the ADHD diagnosis pathway. And if it's really more serious stimulant or opioid use or just a much more serious alcohol use, say, then that probably wants the care and attention of substance use experts, and probably best not to go too far down this path without that support. And there are other tools that can help you take a closer look at that. The QDIT tool, looking at cannabis use, audit tool, alcohol use, and again, some resources that are there to support you in your thinking and how you look at that relationship between ADHD and substance use disorders. An overview of that for providers and support and education for patients. Next slide. And then psychiatric conditions overview. And again, if there are mild to moderate things that we're going to see fairly commonly, anxiety, depression, those can coexist with and may well travel along with a diagnosis of ADHD. If we think those things are mild to moderate, it's probably fair game to continue down this ADHD pathway. If there's more severe psychopathology, probably time to step back and get some help. Referral to psychiatry if you can make that happen. We're lucky that's getting a little easier on the North Shore through the Hope Center in recent times. But if it's more in the mild to moderate territory, then that's probably falls within our purview of addressing. And some of the tools that we think are probably a good idea to do with every single patient is the PHQ-9 and the GAD-7, just to get a sense of how much anxiety or depression might be playing into some of the symptoms. Sometimes you get a surprise there. It can go either way that you think that there's more anxiety here. It turns out there isn't as much anxiety as you thought. Maybe there's more ADHD here that's influencing things than you realized, and conversely. So we think it's always a good idea to do that somewhere around this stage of the discussion. Next slide. And so somewhere along the way during this diagnostic phase, you can sit down and have a look at these things, make sure that you've done your due diligence in looking at these rating scales. These are very helpful, objective ways of looking at things. As I said earlier, they're not the whole story in themselves, but they really help flesh out the story and bring objectivity into what are otherwise our clinical observations. Next slide. So, having traveled that path, I really like this slide that lets us say, good, I've gone through a diagnostic confirmation series of steps. And notionally, if we're going through this in a good way, you can check, literally, physically check every one of these boxes to say, good, I did the ADHD, considered it at first, had a look at the child developmental history. That's important. We want to see that trajectory from early times, if at all possible. Want to see it clearly identified in the adult history that things are going on now. We look at medical comorbidities, substance use, psychiatric co-occurring disorders, and rating scales, looked at all of those things. And using all of that, and there's a patient summary also that lets you go through that. I won't go into that at the moment, but it helps you organize all of these findings from the various assessments and confirm what your impression is going to be coming out of all of this, and determine if you think that this person has ADHD. Next slide. So then, turning to treatment and having a look at that, we think there are two aspects to it that really deserve attention. And one of them is pretty familiar and the other one not so much. So I'm going to deal with the not so familiar side in a moment. But the medication side is the one that we all hear about. And I think patients come to us thinking, if I have ADHD, I want the pill, thank you, because I've heard good stuff about it. And that's a whole conversation in itself. And we'll come to that before very long. But the other one that we wanted to kind of focus on a little bit is executive function skill training. And really the objective and the thing that we're on about here is to help people with their executive function, to help them go through life in a more constructive, straightforward way. Because often if you have ADHD, you're dealing with the challenges of existing with that thing. And maybe you found ways of accommodating to it with a somewhat altered way of managing things. And that may end up being dysfunctional in its own right. So one of the tasks and one of the tools that we have at our fingertips is executive function skill training, which I'll explain a bit more in a second. And what that involves is helping people recognize and come to different ways of dealing with some of the day-to-day tasks that are maybe getting in the way, that maybe decades of dealing with ADHD have taught them new ways of dealing things that aren't always well functioning, or help put them in the way of not always dealing with things, so that their life has gone astray in some of the ways that we've already talked about. So executive functioning is a skill that we need to learn so that we can teach this skill to our patients. So we'll take you through that a little bit and have a look at what that means in practical terms. And then Genevieve, in a few minutes, will take us a little bit deeper down the medication path. So next slide. So executive skills function training, really what we're trying to help the person with is their executive skills. It's planning and organizing things, managing time effectively, sustaining attention in the right moment, and frankly, refocusing education and attention when they need to, because sometimes there's a bit of hyper focus on certain areas, that can be a sign of ADHD in itself. So sustaining attention when and at the right time when you need it, and regulating emotional and impulsive responses, which are sometimes part of ADHD. So it's looking at any or all of those things along the way and thinking, how can I help you with some of these things? So then what we do with that in more concrete terms is set SMART goals. So you've probably heard the term SMART goals before, but just to run through it quickly, it's something that's specific, measurable. We want to be able to put numbers around this, somehow achievable and realistic for the person, relevant to what the person's actually doing, and time bound, i.e., let's do this for the next 2 weeks or 3 weeks or 4 weeks at the most, and then we'll step back and see what came of it using our SMART goal framework to address this thing. And there are some tools also that can help you do this along the way. Mindspace, HealthLink, and even our local mental health clinicians that we have through the PCN Primary Care Network can be very helpful. And we've flagged some other resources on this page. Next page. Next, yeah, thanks. So executive function again, just those things: organization, time management, attention and working memory, emotional regulation. That's an important aspect of what we're talking about. Task initiation and task completion, getting those things happening in a more consistent way to help the person. Next slide. And why it matters, it's a core impairment. That's really what we're talking about with ADHD, is executive function is what has been impaired for the person. Affects daily function more than the symptoms might be obvious, because it can affect all kinds of areas of function, both social, academic skills, even physical skills can be affected adversely. So the skills can support medication effectiveness. The two of them can work really well together. And again, this is something we can do in primary care. Next slide. So here are some examples, and I won't take you through every one of these, but this just gives you a layout of some possible SMART goals that you could use to help the person look at executive functions. So the person might already have said to you, the patient might have said, well, time management is an issue for me. Seems like I'm late all the time. I'm always underestimating how much time is going to be taken over this project. Uh, and you might say, good, let's have a look at that. There might be a way that we can create a bit of a task out of this, a SMART goal, and let's have a look at that. You need to spend a bit of time explaining the SMART goal thing to the patient. And then once they get it, they'll understand, okay, this might make sense. Let me have a look at this. And hopefully they'll find a way to bring forward something that could apply to them. But again, we've given a series of possible entities that you could throw out to the person if nothing comes to mind right away. You could say, well, what about getting started on stuff? What about emotional stuff? Do you fly off the handle a little more than you should in stressful situations? Is that an item? And it can be a fun conversation talking through these things, because this is what's affecting the person, and we're looking to give them concrete ways to deal with that. Next slide. So how do we do that? Just taking one at a time in a visit, set a SMART goal, which we've kind of described there quickly, and giving them a sample strategy and saying, yeah, what if you used a planner? What if you used your smartphone to put stuff into, so that you don't lose track of it and it's going to be there, and you'll have a little reminder a week down the road to have done this thing, and you'll get to it after all. And let's schedule a visit in a couple of 3 weeks and see what became of this thing. If it's successful, great. Then you might say, let's keep that, and we'll review it again in times to come. And if that hasn't been successful and isn't working with the person, you could say, okay, fine. That didn't altogether make sense. Let's think about that one. Let's take another one. Let's take a look at our list of possibilities here. Or let's throw some ideas around and get something happening. Next slide. So again, the SMART goals framework as described, and again, occurs over a series of GP/NP friendly visits, 15-minute things to touch on this. Say, how'd it go? Did you use it? Did it work? Um, did you use it consistently? Did that actually make a difference? Do you think you're going to keep using that? Because it sounds like it might be a good thing if you kept doing this. So again, GP friendly visits that are going to work. Just keep coming back to that. Next slide. So example, again, time management support, chronic lateness, using support strategies, alarms, time blocking, setting aside blocks of time. There's something called the Pomodoro technique, taking 25 minutes of effort and then a 5-minute break to help you improve focus. So there's a number of techniques out there that we can learn and that are also available through various resources that are there on our pathway that we've created. Next slide. And when to consider medication, and I think this is around the time that I hand back to Geneviève. But when there's persistent functional impairment and you feel like, good, those executive skills things work to a point, but not as well as they could. And again, the synergy of medication and executive skills rethink can often work really well together. Sometimes there's a patient preference that may really want to try the medication. And once you've done your medical safety review, uh, good time to start thinking medication thoughts. So I'll hand back to Geneviève.
Thank you, Dean. Next slide. So just wanted to say that whether or not your patient ends up with an ADHD diagnosis, these are good conversations to have with your patient and allows you to get to know them much better. They might end up with an ADHD diagnosis and decide that they don't particularly need or want treatment at this time, and that's okay too. Again, the going through the process, I think, is helpful for both the patient and the practitioner, and it can always be revisited if they change your mind or if their situation changes as they go through life. So the goal of treatment is to improve their patient's quality of life by decreasing their symptoms and improving their functional outcomes. And so when you consider treatment, also important, and I'm talking about medication because often people are a little bit scared to start stimulant medication. Just want you to consider the consequence of not using medication for people who are severely affected. It can be very positive and generally very well tolerated. So this is, excuse me, just the first sheet on the medication from the pathway. Okay, next slide. So before you land on a particular product, you need to do a medical review that includes the diagnoses that are listed there. So this is not an exhaustive list, but includes things like, obviously previous sensitivities to stimulants. Somebody with narrow angle glaucoma, that would be a problem if just make sure, again, they don't have a significant psychiatric condition, things like untreated thyroid conditions. I'm going to spend a few minutes on cardiac issues because often people are worried about that. And so obviously a stimulant and a non-stimulant medication should both be avoided when patients have a known structural heart disease. So that would include like left ventricular dysfunction, myocardial scarring, left ventricular hypertrophy, significant valvular disease. So these patients should see an internal medicine specialist before they would start medication. Same thing if they have an arrhythmia or if they have untreated hypertension. By untreated, I mean that not responding to treatment, not suggesting that you're not treating their hypertension. You're doing your best, it's not working, and it's not at a good rate. Because on average, both the stimulants and the non-stimulant will increase heart rate by 5 to 10 beats per minute and systolic blood pressure by 4 to 6. So if your patient is relatively young, has no cardiovascular history, and has a normal exam, you don't need to do an EKG at baseline before starting them on medication. Okay, next slide. So Dean kind of alluded to some of the comorbid issues, and so this is just to go over that a little bit. There are people who will have comorbid anxiety, depression. Then you have to figure out whether they're secondary or primary. And if a person prefers to treat because it's more symptomatic, the mood disorder, you start with that. If the ADHD symptoms seem to be more problematic, start with that. Again, reminding you if there's more severe psychopathology, definitely if there's any psychotic disorder, that's not something that we recommend you treat. You should refer to psychiatry. Next slide. Substance use, I mean, quite common in the population in general. I think feels like everybody in BC is using cannabis, but it's something that you should definitely inquire about. If it seems to be more than mild or you're not sure, as Dean mentioned, you can use the audit or the QDIT to have a better idea of the extent of their use. Next slide. So again, around menopause, perimenopause, there can be some changes. There can be some brain fog that affects about 50% of midlife women. Usually that's mild and transient, and it peaks actually premenopause, and it improves once menopause is over, although the duration of the menopause can be, the premenopause period can be quite variable. As opposed to ADHD, obviously, where the symptoms originate in childhood and have persisted. That being said, as Dean mentioned, you may find that the perimenopausal brain fog kind of unmasks what was previously a well-compensated ADHD pattern. Next slide. And again, in older adults with potential dementia, again, have a look at the history, ADHD being lifelong, whereas with dementia, this would be a new onset of symptomatology. Around their memory issues, ADHD is more a problem with encoding information, whereas the dementia is more of a problem with retrieving the information. And then the indicators as listed below. The pattern is lifelong. A person without dementia who should respond to executive functioning strategies. It's typically no new language or visual spatial deficits in someone with ADHD. There might be a family history of ADHD that puts you towards the ADHD, and insight is preserved most of the time. Okay, next slide. So this is the main page on the pathway that describes the medication start and implementation, and then we'll break that down over the next few slides. Next slide. Okay, so there's stimulants and non-stimulant medications. I will just say that not recommended that you quote unquote try medication to help in diagnosing ADHD. By the time you get here, it's because you're confident that your patient has ADHD and they feel that medication is needed. You shouldn't just kind of throw Concerta their way to see if they're better and make that be a diagnostic tool. It's not. So a lack of response doesn't rule out ADHD. Some patients can respond to one drug and not to another. And also a positive response to a stimulant, it doesn't prove ADHD was the problem. And you can have, for example, somebody might have sleep apnea and then you give them stimulant and they're more alert, but you're looking at a different diagnosis. So the preferred way to start, the accepted first line is long acting when that's financially possible. We'll go over that as we work through. So medication supports, but it doesn't really replace skill building. And so you really need to do both. Otherwise, you might run into situations where people go, my medication just isn't working anymore, because they're confronted with a new challenge. Something has changed situationally in their life, and they're lacking in the skill building and executive function side, and they're not coping. And so that does need to be addressed in tandem with the medication. All right, and so what we're going to be going over are general guidelines. Of course, the practitioner discretion always applies, but as with any medication that we use, start slow and go slow and start low, pardon me. Next slide. All right, so for the long-acting stimulant options, it's preferred because it's simpler dosing and it's a sustained symptom control. So the three that we're talking of in the pathway, Concerta, Vyvanse, and now Foquest, because that's also covered in DC now. And so then that gives you both the methylphenidate and the amphetamine options. You might need special authority. We'll go over that a little later. Next slide. So starting with the long-acting, there isn't really any evidence to show that methylphenidate is better than amphetamines. So you pick one. If they have a preference because their uncle, their girlfriend, their cousin, their neighbor is taking one and they have faith that this one is the right one, that's fine. If you have a personal preference because you've used it more and you're more comfortable, that's fine. And so you start with a low dose, as listed here, and then at least every week, it could be every 2 weeks, depending on, obviously we're busy. You might not be able to see people every week to adjust their medications, but every week or two, you move them up and you continue increasing the dose until they're either well on that dose or they don't tolerate a higher dose. So both classes have similar efficacy and tolerability by and large. And ideally, you would do an adequate trial of both classes before you would move to a second line agent, like a short-acting psychostimulant or a non-stimulant medication. Next slide. Okay, so this is kind of a clearer view of what I was saying here. It repeats a little bit what's on the previous one. Next slide. So for the short-acting dosing schedule, same thing. There's no Foquest. It doesn't come as a short-acting. So it's methylphenidate, which is the Ritalin. It's short-acting, or you also have the intermediate-acting as the Ritalin SR, which is also covered. And then you have dexedrine immediate release or the dexedrine intermediate release as well. And some people end up being fine with those. If you end up not being able to, if they can't afford the long and you start them on the short, and then you end up with an SR Ritalin or a dexedrine Spansiol, and you find a dose that works for them, there's no, you don't have to move to the long acting if that's not possible or necessary. So same type of idea for this. Every week you move up and then you increase the dose until their symptoms are well managed or they don't tolerate a higher dose. Next slide. So in order to have your long acting covered in BC, you have to do a trial of the short acting. If a person has good coverage through their work and they can pay for a long acting, and then they change jobs, you're going to have to go back to the trial of the short acting. Usually they're not going to accept, oh, Frank has been on long acting for a while, works really well for him. Can you pay for that now? They'll probably say no. So you have to go back to the short acting trial. It's not a long trial. You have to try at least 1 week. That's the documentation that's required on the special authority form. And you have to give a reason why it doesn't work. So that may be that, the medication is wearing off even at a high dose, you're not getting a good response, or they're getting a higher unacceptable level of anxiety with the short-acting stimulants. Just as a note, Health Canada doesn't recommend that you would substitute for the methylphenidate, that you would go from intermediate acting to extended release on a milligram for milligram basis because the pharmacodynamics are different. So don't do that. Okay, next slide. So the non-stimulant medication, this is sort of the main page here. I won't go through all of that, but it goes in a lot of detail around how to dose and titrate it and the side effects. So the next slide, please. We just mentioned the atomoxetine. It's the only one that has coverage in BC. There's other products like Intinif, for example, but it's not currently covered. There's other products that are in the works, but they're still awaiting Health Canada approval, so we're not mentioning those. So this may be more appropriate for a patient with very severe anxiety, tic disorders, substance use issues where you might be concerned about abuse of the medication, or just generally poor tolerability to both trials of stimulants. So you try the methylphenidate and the amphetamine, and they don't tolerate either. Just to mention as well that using atomoxetine along with the stimulant, so that's considered off-label, which would be kind of a more complex use. So we're not discussing that in the pathway either. Next slide. So this is a super busy slide, but that's the CADRA guide to ADHD. That's on the pathway. It's on the CADRA website. And it's a very good kind of summary of all the meds that are available, along with what doses they come in, what their half-life is, what you can do with them. You know, some of them you can break open, like the Vyvanse, you can break it open, put it in a cup of water, and then separate it out over 3 days if you want to change the doses and not have to have them get new tablets. Next slide. So, okay, so next one, we're going to just, again, general page on section for education, safe use, and then monitoring side effects. Next slide. So there's common side effects which are mild and usually well tolerated. There's rare, serious, uncommon side effects. I'll let you read through all of that. Obviously, if there's anything that's serious, you stop the medication because it's not chemotherapy. It's not life-sustaining, and so you stop that, and the whole thing needs to be reviewed. You need to revisit the appropriateness of your treatment. Because as for medication treatment of ADHD, both the diagnosis and the treatment, there's nothing urgent about it. You can take lots of time, go back and forth. If things don't seem to work, you take a step back and revisit what you've been doing. So there's sheets in the pathway on the CADRA website. BCH has a side effect sheet if you want to print some of those off and give them to your patients. If you think that's going to upset them and they'll come back with every side effect listed, you can be judicious with what you tell them, but you do need to make them aware of the fact that side effects can happen. Sometimes it can be helpful to have them fill out the side effect profile sheet before they start the medication to see what they already have. So then after that, they can't blame the drug for things they already had before they started the medication. Okay, next slide. So if the symptoms are well controlled, you stay on your same dose. If the symptoms are not well controlled, you increase the dose, as we saw in the previous slides, as tolerated. If it seems to wear off earlier than you expect, often it's because a higher dose is required. And we recommend that you only prescribe the amount that you need until the next planned visit to reduce any kind of leftover medication. Next slide. It's important to spend some time talking to them about safe use and storage at the beginning when you first introduce medication, and also sort of periodically remind them of that. Next slide. So it's obviously meant to only be used as prescribed. It's not to supply their cousin with medication. And they should store it well in a secure place, maybe even locked, depending on who's in their house. These are adults, and so they may have children, teens who also potentially have ADHD, and may be tempted to try their parents' medication, or another adult with medical conditions that you have not vetted for use of the medication and who should not be taking it just because their husband's on it. So if they miss a dose, they should be told to take it as soon as they remember, unless it's quite late in the day to avoid insomnia, but they shouldn't be doubling up on a dose. So if they say, oh, I don't know, did I take it? Did I not take it? Then you don't take it. It's not metoprolol. They can skip a dose. They'll be fine. Okay, next slide. So this is, I'm not going to spend too much time on this, but we do, just to say, we do have pages in the pathway, on medication coverage. There's also pages on billing, both for LFP and MSP billing for these visits. The whole host of different coverage types. Next slide. Plan G, special authority, extended health benefits, fair pharmacare. We're very lucky on the North Shore. We have, through the PCN, pharmacists at our disposal, who can help us navigate some of this. If you're not sure, or your patient is unsure how to apply for these things, what might work for them, our pharmacists, I've used them often, and they're great. Next slide. So this is just reminding you of Plan G. It's income-based, and so it's not for necessarily for everyone. You have to do the application every year. You sign your section, and then you send it off to the Hope Center. And it seems like it then kind of goes into a bit of a void. Like, I know I never get any feedback really from them, but you hope they do it. And so tell your patient if nothing seems to come of that to let you know. Next slide. So for special authority, as I mentioned before, you have to apply. If you apply online, if you do an e-form, it's the turnaround's a lot faster. If you feel there's somebody who needs a quick acceptance, you can also call them. Like they're usually very good at doing it right there. They'll just approve it right away um, if it's urgent. Next slide. And then again, just a reminder to make sure that residents are all registered for fair pharmacare, especially if you have a family where multiple members might be on ADHD drugs. It can make a big difference. Next slide. And so I'll pass it over to Dean to talk about the next section.
Excuse me. Yeah, thanks, Genevieve. Thanks everyone for your patience in hearing this and your interest in it. So this is one of my favorite parts, actually, seeing ADHD as chronic disease management. And really, what we're saying here is and you'll recall the slide early on with the little car going down the road. That's really the path that we're on. We want to normalize management of ADHD as chronic disease management, just like we manage every other thing that we do so much of. So if someone has a heart problem, you don't say, "Oh my gosh, you have a heart problem. I guess I'll never see you again. You're off to see the heart specialist now." It doesn't work like that. We keep seeing the person, adjusting their heart medications as need be, and the heart person, the cardiologist, sees them every 6 months or every year, whatever seems appropriate according to the case. And it's the same thing here. We can manage ADHD. We can do a lot of the day-to-day troubleshooting and management. And if it really is at all complicated, then it's reasonable to have a specialist help look over our shoulder at the thing. But really, we are in a strong position to manage this. One of the reasons that puts us in a strong position is because we know the patient. We might be in a better position than a psychiatrist or someone who doesn't know them as well to be alert to possible diversion, possible substance use, possible other co-occurring problems that we might be aware of that someone else might not be and would be concerned about. So we're in a strong position to manage this in a sensible way. And our patients trust us. We trust them. Once we get to know them, we usually know what's going on with them. So we have the longitudinal care relationship, regular opportunity for reassessment. We can adjust the treatment just as we would with diabetes or blood pressure or asthma or anything you can think of that we manage. We can adjust things as circumstances change, as the medications, the impact may change for them over a period of time, and we can just simply normalize the reassessment and refinement of their care as we go, as we do with so many things. Next slide. So recognizing optimal progress, again, we've kind of talked about that. What does progress look like? We've talked about how are things going? Are your behaviors changing? Are there certain things that you're finding you can do more easily? Are the medications having a favorable impact? Have you tried out some of these different ways of doing things, executive skills, executive function? So you can ask questions like, have you noticed changes in your ability to stay focused? Is it helping you? Is it easier for you to start and finish stuff? Can you stay focused longer? For how long are you able to shift the focus onto things that you really need to pay attention to? Can you return to a task fairly easily after getting distracted? You can ask those kind of concrete questions, just like we'd ask someone with diabetes. How is it going? Are you walking more? Or do you have more energy? What about weight loss? What's happening? All those kinds of things. Explore the specific impact on aspects of their life. And it isn't just the school and the learning and the work. It may be relationships and social function. And again, there's even a physical safety aspect to this, that people tend to have less accidents and less mishaps when they're appropriately managed in ADHD. So how's all of that going? And again, you can reuse the rating scales that we talked about in early times to make the diagnosis. You can use those scales again and say, let's have another look at your ASRS, see if that's changed. What about your PHQ-9? How has that changed? Or your GAD-7 after some period of time on medication or doing things differently? How has that changed? Those things can be, again, objective ways of knowing what the progress is looking like for the person. And again, just like anything we do, reevaluate if it's not working. Think about what else can we be doing? Would a medication change make sense here? Are there other things we should be doing to support this person? Are there other ways, other providers that might help? Mental health clinicians, even an OT or coach or CBT could help this person do a little bit better in various situations. Next slide. So what does progress look like? Again, some of those things that I've alluded to, this just breaks it out a little bit more specifically. And again, progress doesn't have to be perfection. We just want to see that we're moving in a good direction. And again, because it's a long-term condition, this is something that we'll keep returning to. We'll keep talking to the person, seeing them maybe every 3 to 6 months or so and talking about how's it going? How's it going? And hopefully we hear that, yes, it's going well, thanks, no concerns. But if there's concerns, that's why we're here. That's what we do with all kinds of conditions. Next slide. And again, how to assess patient progress, functional domains, looking carefully at all of those domains of functioning, whether it's school and learning, recreation, relationships, financial, work aspects. There's 4 or 5 key areas of functioning that we all live in, asking questions about each of those areas can be very helpful. And again, the rating scales and clinical observation. And one of the things that I think is helpful, it's not listed here, but collateral information. Often, again, as GPs, we know the family members, and you might say, "What does your wife think about this?" Or you might say, "Do you mind bringing your wife next time?" Because sometimes having another set of eyes on a situation really helps, not just for ADHD, not just for mental health things, can be other things. Sometimes bringing a family member in and asking the person, "Do you mind if we bring your wife along next time?" Sometimes family members, not to personalize it to them, but just to say sometimes family members and other people have interesting aspects on ourselves that we don't even appreciate ourselves. So how about if we bring that person in? Sometimes you'll ask the person, "What does your wife think? How does she think you're doing with all of this?" And they'll often be very forthcoming in saying, "It's made a big difference to her. I don't perceive all the things that have changed, but she's saying some things are better about what I'm doing. So have to listen to that." So it's really helpful to ask that and sometimes seek collateral information. So that can be part of assessing progress. Next slide. And if the response is partial, yeah, have we reached a good level? Is it even the right medication? Sometimes a switch from Concerta to Vyvanse can make a difference. Everyone has different physiology. We all respond a little differently, especially to the psychoactive medications. Would some of these other resources be helpful? OT, coaching, CBT, workplace supports. What about that? Or schooling supports? Would there be some differences that could be helpful there? Next slide. And reevaluate if you're not seeing a good improvement, consider a change of path. Side effects might outweigh the benefits. We have to look at that. Sometimes mood worsens depending on the situation. If have we looked enough at their underlying depression? Is there something more going on there than we appreciated initially? Or emotional blunting occurs, and I think we have to be careful with that one. Sometimes people's emotions, they're very calm, and there's less of the ups and downs, and they might perceive that as emotional blunting, but maybe they're just slipping into a new, more manageable way of being and experiencing things. Or it might be that they really are experiencing an uncomfortable blunting of emotions, and we hear that one. Or is a different diagnosis to be entertained? And again, consider misuse or lack of engagement in this whole process. Next slide. So some of the ongoing challenges, yeah, adhering to the medications, adhering to the executive function things. Sometimes the dose really does drift over time and you need to increase the dose. Emerging anxiety or depression, where life situations happen, life keeps happening and different things need to change in the management because other things have changed around the person. And next slide. So these are some supports. Again, we've Genevieve mentioned accommodation letters in the workplace or schooling situation. Workplace supports might be worth a thought. Disability tax credit. Usually, I find that they're very specific about what can be supported and what can't be supported. And if you put something out there that's a little tentative, I find that Canada Revenue will come back to you and say, "Can you be more specific about this? How far is it that they can't walk?" Or that they walk before they get short of breath. What's the actual, give me some specifics. So I don't worry as much about that one, but there may be a place for that in the right situation. And again, set realistic expectations for the patient. Say, I can only say so much in support of your cause. There's a legal aspect to this, and I can only say what I can say medically. Next slide. So again, this is just laying out the maintenance, showing it in one page, some of these things that we've talked about. And again, I think a follow-up interval, as with many chronic illnesses, 3 to 6 months probably makes a certain amount of sense. And again, subject to our judgment, subject to us knowing the patient. We know them, we know what might make sense for this person. It's not going to be identical for everyone. We get to use our judgment. And as far as flexible dosing, some patients really might benefit from flexible dosing depending on their needs. And some people may say, I really want to do the medication holidays. And personally, this is just my bias as a non-expert. I'm not a fan of medication holidays because I think that the influence of the medication is more pervasive than just the workplace or school. I think it has benefits in relationships, again, safety, decreasing accidents, decreasing impulsive behaviors that sometimes aren't obvious to the person, but they do happen. So I think that there's an argument to just stick with the medication. It works well for you. Having said that, the medications are usually really flexible, so the person can stop them for a few days and then restart them in a few days and end up in more or less the same place. Unlike some of the other medications that we use, where the antidepressants, for example, if you go off them for any length of time, then you have to go back through the path of adaptation and neurological change that takes a month or so to play itself out. And prescription renewals, again, just being very careful and structured about it. The lost pills and the pills going down the drain, sorry, we can't help with that one. You need to be really careful with these medications. They're strong medications and effective, and we need to use them carefully. So that's a form of monitoring the use and the misuse and misallocation of the medications that we want to protect against. Next slide. Yeah, so follow-up and monitoring, as I've outlined, every 3 to 6 months-ish, depending on the patient, and keeping an eye on some of the other things that you might be concerned about, depending on the patient. Again, blood pressure and heart rate, side effect issues, again, reusing some of the tools, and functional outcomes. And again, taking a close look at that and using whiffers if that's what you need to use in order to understand what the path is looking like. Next slide. And prescription management, again, flexible dosing, if you think that's reasonable, medication holidays, if you think that's reasonable, prescription renewals, maybe keeping a maximum of 6 months, maybe 3 months, maybe you might think 2 months makes sense for the person. Again, the individual, and you can use the race line for support, quick reminder. That we like to put as many tools in your hands as possible. But and then patient resources, ADHD care pathways, other tools that you may find handy for yourself and also for the patient along the way, things that you might want to send them. Again, many of these have the little envelope beside them because they're available on Pathways, and we can send them so easily using Pathways as our background, our infrastructure for doing all of this. So just to say, there's a lot of stuff there. You can have a look at it at your leisure. This pathway is easily available to all of you at a moment's notice. So again, and further resources, mind space, skills for success, ADHD strategies for adult mental health clinicians through our primary care network. And again, the PCCPs, primary care clinical pharmacists, can be helpful. And national organizations, CADRA and CEDAC, Canadian Center for ADHD Awareness of Canada, and How Do ADHD, a YouTube by Jessica McCabe. So those are just some of the tools that you might find handy. Next slide. Yeah, and over to Geneviève.
All right, so we're getting near the end, and we'll take questions very shortly. Just wanted to take some time to acknowledge this is kind of the group of people that did this. That the top line, that Dr. Betty Tang and Dr. Elizabeth Berghall are two psychiatrists on the North Shore, and they developed the documentation, really the information, and then the family physicians sort of supported and critiqued and said, well, this might work, this might not work. And then we presented that to a larger group of doctors that you see at the bottom. That's our advisory group. And top right are the potentially the two most important people in our ADHD group. So that would be Cynthia Bucket and Alex Moros Witek. So they're both online today. And Alex has been our IT person, and Cynthia was our project lead with Alex. And so they've been so helpful and a joy to work with. Next slide. So this is our evaluation form. If you want to quickly click on that, and please fill it before you leave. Just leave that there for a sec, and then I'll take it away to keep moving. So if everybody can do a quick photo.
Or fill it out later and send it back to us if it comes to that, if you don't have time in the moment right now. But
Yes,
we
yes, you
really
don't have to
value
fill
the
it now.
evaluations.
Yeah,
They're so
just
important.
just capture the form. Next slide. All right. So to the right is a link to the ADHD care pathway, which you can find on Pathways as Dean discussed before. And then we'll go on to questions. So I think Cynthia's been looking at the Q&A section. And so I'll let us know what the questions might be.
And just while Cynthia's gathering the questions,